Thank you, sir. The next session is session 10. Let's discuss advancement in orthopedics. Advancement, the role of navigation in joint replacement. I would like to call upon the chairpersons, Dr. J. Chaudhary, sir, Dr. Subhash Chandra, sir, Captain Dilip Kumar Sinha, sir, to chair the session, please. The first speaker is Dr. Nishikant, Advancement in Knee Replacement, Manual to Navigation in TKR.
What's that? Acha, AMC. Which one, sir? This. Sure? Hold on, sir.
Session 10 करके डाला होगा. Session 10. Yeah. Point out.
I'm giving you, sir. Pointer.
Okay, sir.
Here it is. Click on this place and right click. Okay?
So thanks a lot for inviting me. So I'll be talking about advancement in knee replacement, manual to navigation. Is the juice worth the squeeze? So total knee arthroplasty is a highly predictable surgery, but it is surgeon dependent. Despite the immense success of total knee arthroplasty, the orthopedic community has continued to innovate. With the survivorship reaching around 98% by the end of 10 years and 90% by the end of 20 years, there's little room for improvement. But we have continued to innovate in many manners. And any innovation must clear a very high bar. So this is Scott's parabola. This has been the fate of all recent innovations. All have started with a great promise in the beginning, gradually becoming the regular treatment protocol by few encouraging reports by industry-sponsored literatures, and gradually falling into disrepute. Talking about the recent innovations, we have all these examples: the short stamps, MIS, navigation, metal on metal. These all came with a bang in the market, and today they are nowhere. So we should be very cautious while choosing the newer technique. So this is the largest reported satisfaction index published by the Swedish Knee Registry. Around 20% population is not satisfied with the primary total knee arthroplasty, and this has reached up to 40% in cases of revisions. So there is always a room for improvement. So how can we get the maximum results in total knee arthroplasty? I think three things are very important: the selection of the patient, your implant, and your own surgical technique. I think the surgical technique is the most important factor. Surgical technique basically decides over the three pillars: the bone cuts, soft tissue balancing, and the cementing. All are equally important, and mistake in any step may lead to failure. So these are some of the recent advances in total knee arthroplasty. So actually, must tell you very frankly, we all are dancing on the tune that we replace an arthritic joint with a prosthetic material, where any change must be substantiated by scientific method, which for centuries which has served us very well. In fact, most of the real innovations in the recent times are fostered by the industry, not by the true academia. So the real villain is the industry. This industry decides the implant design. This industry decides the implant longevity. They influence the surgeon, and they influence these scientific meetings. They propagate myth and hypes. So coming on to computer navigations, can be either pinned or pinless, which can be eye assist and all. So look at where they really stand. This is the National Joint Registry 2020. Only 4% surgeons use navigation. Coming on to Swedish joint registry, number has increased, but there's a continuous decline in the trend. This is the Australian joint registry. The number has gradually increased in Australia, reaching up to 33% by 17. But look at the results. Less than 65 years, there's decreased risk of revisions, but above 65 years, there's no difference in the revision rates, which is the most common age group in Indian scenario. You will find in number of literatures comparing the conventional versus navigation, and all conclude to a single point that navigation provides improvement in the component alignment, but there is no difference in the functional outcome. Look at the American Academy recommendations. There is a strong recommendations of not using navigation interoperatively because there is no difference in the functional outcome. So advantage of navigations, mostly three and the two theoretical. They may take few bony cuts more accurately, don't violate the melodic lance or theoretically decreases the risk of pulmonary embolism, more useful in certain conditions where there is intramedullary implants, but there are many disadvantages. There is no evidence of better functional outcome, time consuming, cost, long learning curve, complications of pin applications. And moreover, soft tissue balancing and cementing is an art, and the surgeon has to master that. So the industry found that this cash is not selling too high, so they have come up with new idea called PSI, but PSI was associated with even more problems. So PSI has a pros, it has less instrumentation, more OR efficiency, but the cutting block don't fit exactly, so there are frequent intraoperative changes are required. So it only help in getting the proximal tibia and distal femoral cuts. Rest, bone cuts and soft tissue balancing and cementing has to be done by the surgeon own. Look at the results of the PSI. Their alignment is much inferior than CAS. There is no long-term data for the PSI, and patient has to wait long for the surgery. So they have come up with the robots. So basically, robots are of three types: the passive, in which they just provide a 3D virtual model without any preparation for the bone; the active robots like the RoboDoc, where the surgeon does the initial planning and the preoperative exposures, but the robot has the capacity to complete the surgery. The semi-active like the Mako, the Rosa and the Navio, where the main command is over the surgeon, but the surgeon's command is modulated by the robots, and they limit the bone preparation and soft tissue damage beyond the treatment plan. Actually, these semi-active, the Mako robots, they receive the haptic feedback from the soft tissue. Surgeon does the ligament balancing, and they do the ligament balancing itself. So look at the outcome. The great promise of robots is that reduce outliers. That is entirely possible. But there are many disadvantages as well, which I will discuss. They have claimed to be decreasing the soft tissue injury, less hospital stay, less postoperative pain. But there are n number of literatures which will suggest that there is no difference in the functional outcome. For total knee arthroplasty, soft tissue balancing takes an edge over the alignment. And soft tissue balancing has to be manual. The robot system only registers the varus and valgus stress exerted by the surgeon. And this is not entirely objective. Rather, it depends on various intraoperative patient and surgeon-related factors. For soft tissue balancing, the manual dexterity, the feel, and the decision-making is of paramount importance. And this cannot be replaced by artificial intelligence. Cost. The cost of robots is decreased by its proponents, but they are mighty expensive. And it needs, just a few minutes more, and it needs eligible number of cases per annum for immediate break-even. Paradoxically, those high-volume surgeons who can afford it don't need it. And those low-volume surgeons who need it can't afford it. There's a need of pre-op CT, which always comes with an inconvenience in addition to the patient. The one incontestable fact is that robots take more time, which is directly related to complications like infections and thromboembolism. So are we just merely exchanging outliers, which has no clinical significance, with complications, which has no solution in fact? This is Malcolm Gladwell, with his famous book, Outliers. He has written that it needs about 10,000 hours of rigorous monitoring to mastery art. The best joint replacement surgeon of the world said the same experience. Is robot going to reduce this threshold and make joint replacement successful for all? Or is it going to rob young surgeons chance to mastery and excel even when there is a power failure? So these are some of the cases. The knee fixed in extension. I don't know how the robot is going to help in these cases. Done with my own robotic arm. Another case. Knee fixed in extension. Patient came up to us with when there is a fracture of the patella. Done with my own arms. You can see well aligned and well balanced knees. So somebody will be, the CAS, PSI and robotics are more of a marketing gimmick. Pros are few and theoretical, but cons are many and substantial. So we should adopt new things very cautiously. So I'd like to conclude by saying that I am not a communist supporter who criticizes every innovations, rather a true nationalist who embraced innovations. But every new innovations must be cost effective and beneficial to the patient before being implemented. Thanks a lot.
Thank you, Nishikant. Nice talk. And any question from the audience? One question from our side. So how do you decide when you will plan for robotic, or you will plan for CSI, or you will plan for your convention surgery? And what should be the take-home message for the junior guys?
You should learn everything. I have learned computer navigation, conventional, but basically I do all my TKRs with the conventional technique right now.
So that should be a take-home message. You should start with your conventional, and as you grow up,
yes,
you can develop with your different operating platforms.
Thank you.
Thank you. Now I would like to invite our next speaker, Dr. Vishal Kumar. He will be talking on, is robotic future of joint replacement, or we still have many more to do it conventional?